Welcome, everyone. We're so excited today to be here at Innovations in Population Health. Got an amazing group of people who are going to share with you what's going on and the leading edge in innovations around population health. So without further ado, let's go into the next slide, if we could please, Tony. So, yep, you can go one more.
Yep.
There we go. Okay, so the first thing we really have to get on the same page with is what's population health. And to make it simple, I've chosen to define the three components. They're health outcomes, patterns of health determinants, and policies and interventions. So when we talk about the population health of your corporation and of what's going on, obviously you're going to pay proportionally to the health of your population, and that's going to be dependent on the patterns of the health determinants and how well you design the policies and interventions inside your corporation. So what do we mean by innovations? Well, we're looking for ways to evolve, improve, and change the status quo. We're leaning in to improve processes and outcomes. We're growing and developing from the experience gained in our last efforts, and what a group of experts we have with lots of experience today. And of course, we want the uncompromising pursuit of what's next and what's going to make a bigger difference to your employees and their family members. Next slide. The four spheres that we're going to really look at today are proactive chronic condition management. We're going to look at community health and community health activity, digital health, and a global look at well-being and what are new and innovative things in each aspect of this. If we could go on to the next slide, please. All right, so obviously we've got to change. Continuing to do what we're doing is not going to get us where we want to. So let's talk about the different things we can do to get those different results. Next slide. All right, so we're going to start off with Bert. I'd like to introduce Roberta Wachtelhausen. She's a visionary and strategic leader of WellSpark Health. She's a recognized expert in healthcare and wellness for more than 30 years. Prior to leading WellSpark, she was a senior vice president, chief sales and marketing officer for Connected Care. She's also held senior leadership positions at the national and regional health plans, including Cigna, Meritain, and LifeCare. In addition, she co-founded a health benefits startup, Roberta Health. So with that, I could continue to go on, but with that, let me turn it over to Bert to share with us her innovations around population health.
Thank you, Scott, and hello, everyone. If you can recall the slide that Scott just had a couple ago with the circle around population health and the elements and dimensions of that, I look at that and say that is WellSpark. And WellSpark is really a well-being and chronic disease prevention and self-management company. And we're really focused on helping people who are trying to prevent a chronic disease or manage one if they've been diagnosed. And we do that by supporting them through a biopsychosocial model of health. So we know that if you have been diagnosed, it's not just about with a chronic disease. It's not just about you managing that. It's what is going on in your life that might be getting in the way of you managing that. And so what we're really trying to do is unlock what is in your, what I call personal orbit. And everyone is different. If a person who's been diagnosed with diabetes, as an example, is dealing with that chronic disease in a way that's different than anybody else. So as unique as the person is, that is the WellSpark solution. And when we think about it, we're really focused on helping the employer who has a long tenured workforce, because we know that that's the kind of employer who needs to make investments in that employee today, because that employee will still be on their payroll or their roster 10, even 20, even more longer years. And so investing in that person's health today is really important for the long-term return on that investment. And the employer that we're really focused on is that employer who has a very diverse workforce, a hard to reach workforce. And we are really focused on meeting the needs of that employer, whether it's geographic diversity or it's demographic diversity, or if or cultural diversity. And what I'm going to talk to you about today is two things that we're really focused on in the context of the backdrop that I just laid out. So next slide, please. So the first thing I want to talk about is chronic disease distress versus depression. And when I talk about supporting that person in a biopsychosocial kind of way, the psycho and the social for us is really wrapped up in understanding what is chronic disease distress. Now, it's been documented, it's been named, and now we're in a very unique position to be able to measure it. And it's different from depression. So the classic screening tools for depression are a PHQ-9. And so in that screening, you're looking for depression, and it actually can coexist. It's an emotional disorder, and it can coexist with chronic disease distress. But what we're focused on here in chronic disease distress, we're identifying it, supporting it. Now, this is the feeling of burnout. You're managing your disease day in and day out. And the treatment here is more education and support rather than actual diagnosis of an emotional disorder. So as we're focused on helping folks understand disease distress, our coaches and our nurses are using a screening tool that's from a company called Silver Fern. Now, Silver Fern Health gives us a behavioral diagnostic tool, and this is the first application of their tool, which is based on 20 years of peer-reviewed science. There are case studies that now are with the American Diabetes Association that were based on WellSpark cohorts that have come through the program. But this diagnostic tool really helps our coaches and nurses assess the person's level of chronic disease distress. How are they feeling? How is the burnout? What kind of support do they need? So we're actually able to measure it. Now, why is that important? Well, chronic disease distress has been tied to hemoglobin A1C in diabetes, as an example. So as we look to lower the chronic disease distress and the burnout associated with having a chronic disease and managing it day in and day out, we know that if we can lower it, we lower hemoglobin A1C, and that's been studied over time. And we actually have several studies in market right now where we're proving this out. But we know employers are always looking for, well, what is this going to save me in medical costs? And so we know there are also studies in market that say that if you can lower hemoglobin A1C over time, you can actually lower medical costs. There is a direct tie. So for us, by lowering chronic disease distress, lowering A1C, we can therefore lower medical costs. And that's the improving outcomes that we're doing with the studies that we have in market and the case studies that have also been published with the American Diabetes Association. So again, this ties back into Scott's model of population health. And it is an engagement model for us to really use these tools to unlock what's going on in that person's orbit, what's going on in their psychosocial world. And we uncover all sorts of things. We uncover that somebody is a caregiver and they're taking care of someone else before they take care of themselves, which we often do. Well, what this tool does is unlock what that is, and then our nurses and coaches can then help that person solve for whatever it is in their life that needs to be solved for. So it's really, everybody's unique. Everybody is dealing with their chronic disease differently. And we're bringing forth the individual solution for what's in that person's life. And that could be hooking them into talk therapy resources, caregiving resources, true clinical behavioral health that a person might need. So that's our latest innovation. We're really excited using the Silver Fern tool. This, again, is the first commercial application of the tool, and it's getting results. So if I could go to the next screen, I'm really excited to talk about the next engagement strategy that we have. So we hear from our clients and we hear from the market that one size doesn't fit all. Not every workforce can be given the same program and have everybody improve their health. So it's not an out-of-the-box solution. So we're really focused on those employers who have a diverse workforce and who, again, it can't the program can't be delivered with one modality. Not all digital all the time, at least in our observation, really meets the needs of today's workforce. And this is where, again, we're focused on meeting the geographical needs of the workforce. If they're dispersed all over the country, if they're not working in an office, but maybe they're working they're driving a truck, or they're on the hospital floor and can't take advantage of regular programming. We're really coming forth into the market with a multi-modality, omni-channel approach so that we can meet people where they are. So our programming is live, it is digital, and it's telephonic. So it really depends on the workforce. And then as we look at the programming, a lot of our programming is based on the CDC or the American Heart Association. And so our diabetes prevention program is a really good example where we've looked at the programming and said, how do we meet the needs of a culturally diverse workforce when all of the programming that's in market, it may be in Spanish and English, but it's really based on the Western diet and Western customs. So if I could ask for the next slide, please. So the shortcomings in our view of today's programming, it assumes everyone eats a Western diet. So this is a page from the CDC's Prevent T2 curriculum, which we use as our basic programming and curriculum for our diabetes prevention program. But as we look at this, it shows how a plate is divided. And it has, your starch in one spot, your veg in another, and your meat, your protein in another. Well, what if this doesn't look like what you eat? And what if you don't eat on a plate? What if you eat in a bowl or from a bowl? What if you use chopsticks instead of utensils? So we are blessed with having a very diverse customer base. And one of our customers in particular is the city of New York, the city of New York employees. It doesn't get much more diverse than that. So we are delivering diabetes prevention programming in the neighborhoods of New York today. And so we stepped back and said, how do we deliver programming that really meets the needs of each of these unique communities? So if you could advance the slide, please. We've taken our lessons from the supplemental materials from the CDC. So we're still sticking to the core. And we're saying, okay, let's take that plate and let's look at what a bowl might look like for someone, as an example, in Chinatown. And what foods do they eat in that culture? And how do you teach the same lesson and bring it forth in a way that really connects with people and really resonates so that you can actually affect change? So for us, this is the circle on Scott's diagram about community, because what we're doing here is we're taking information and the cultures from so far we've done Crown Heights, Harlem, Chinatown, East New York, and we continue to convert our materials to be very, very culturally relevant, to be able to connect with the people who are actually in our programs. So it is biopsychosocial, yes. It's unlocking what's going on and solving for disease distress as we're leaning into new things to measure in the market in order to get success. But it's also engagement tactics and techniques like the programming that you see here that really connects to the people that are deep in the neighborhoods of the people we serve. So Scott, that is my prepared remarks and presentation, and I look forward to questions.
Fantastic. And I'd like to ask the folks who are watching the program today to please go ahead and put your questions in the boxes, and we're going to integrate those questions into the program as we go forward. If I could get you to go ahead and go to the next slide, please. Thank you so much for those wonderful comments. All right, so I'd like to very briefly introduce Dana Udell. Dana spent the last 2 decades helping individuals and groups make positive and enduring changes in their lives. She's a licensed psychologist with a PhD from the University of Southern California and pre- and postdoctoral training from the University of Pennsylvania. The cornerstone of Dana's work is her belief in the power of relationships to help people heal and grow. Dana, with that, I'll turn it over to you.
Great. Thank you so much, Scott. Well, glad to be with everyone today. I'm Dana Udall, Chief Clinical Officer at Ginger. What this means is that I oversee the care team. So overseeing coaching, therapy, and psychiatry. Those are the levels of care we offer. And that means everything from interviewing our staff to overseeing QA to actually being on call and providing consultation to our coaches and clinicians when they need it. So happy to talk with you a little bit about the Ginger model and how we're innovating on care. So if I could have the next slide, please. So one of the things that is really axiomatic and we know about mental health care is the supply-demand imbalance, which is only getting worse over time. So we have many more people seeking care than in the past. In part, this is due to decreased stigma in some groups. We do an annual workforce study in which we look at employee beliefs around mental health, what employees are asking their employers to do, how they're feeling about stress in the workplace in general. And we found that 96% of employees report that COVID has affected their stress levels. 70% of this group has said that COVID has been the most stressful thing in their professional career, more stressful than 9/11, more stressful than the recession in 2008. So more people are coming forward, raising their hand and saying, I have a mental health issue, I need support, and turning to their employers to provide a solution to get them access to care. What often happens, though, is that there is not enough supply. So we have fewer and fewer people going into the field of psychiatry, for example. Wait times on average are about 25 days. So once somebody attempts to seek care, it can take them almost a month, sometimes several months to actually get in and see somebody. And in part, we can understand this because up to 50% of American counties have no mental health provider. So nobody is around. There are just these sort of mental health deserts, you might think of them as. So not a lot of options for care. I have worked in many of these clinics where, you have a line out the door, people are starting to come in and you just cannot see them all. So what this speaks to is the need to innovate on care and find new ways of reaching folks and increasing access given this provider imbalance. And as I said, it's predicted to get worse. So by 2025, 250,000 is what the estimated mismatch will be between provider and those who are seeking care. Next slide, please. So at Ginger, what we are doing is creating a mental health system in order to provide care at the moment of need. And the way that we're doing this is by these multiple levels of care, as I've mentioned. So most members come onto our system and they start with a coach. Coaching is an incredibly robust service. About 90% of the folks on our Ginger system stay at the coaching level. So coaches typically have master's degrees. They're able to work with people on anything from stress management to managing symptoms of a diagnosis like major depressive disorder or generalized anxiety disorder. Members are able to talk with a coach typically in less than 60 seconds. So they download the Ginger app and they start talking immediately. One of the things that we've noticed is a huge increase of utilization overnight. So since COVID started, we're seeing a 50% increase between the hours of 10 p.m. and 6 a.m. So what this means is that folks are not sleeping. And we know that there are huge consequences to lack of sleep. So physical health consequences, mental health consequences. But thankfully, because they have Ginger, they're able to get that support, maybe do some breathing exercises and calm down in the moment so that they can get back to sleep and have a better day the next day. We also have therapists and psychiatrists within our system. So this is all through the ease of your smartphone. Members can talk with a coach in a text-based modality or be escalated to therapy and psychiatry through video visit. So again, all within our system in a collaborative care model. And then we have personalized content. And a lot of vendors have content. One of the things that's unique is that our coaches will curate and send out particular exercises. So if someone is struggling with anxiety or perhaps parenting or working from home in isolation, we have exercises and content that address all of those issues that are then sent to members. So we're a licensed medical PC operable in 50 states, providing therapy, psychiatry, and coaching, providing coaching to 34 countries around the world. So we work with lots of employers, everything from very small employers to jumbo accounts. So have lots of different industries and verticals as well. So if we could go to the next slide, thank you. And I want to talk a little bit about how we innovate on mental health care, given that it is so important for increasing access, as we talked about at the beginning, and really solving the behavioral health crisis that so many folks in our country are experiencing. So this on-demand care is huge. Again, in order to really cut down on wait times, the ability to go on and get care at the moment of need is incredibly powerful. One of the things this does also is it can head off more severe or serious behavioral health issues that might arise down the line. So at Ginger, a lot of what we're doing is prevention work you don't need a diagnosis, which is something that's pretty profound in our healthcare system. Typically, in order to get therapy, for example, you have to have a set of symptoms that meets diagnostic criteria so a payer will actually pay for the care. But at Ginger, you could be struggling with stress or anxiety about a presentation at work, or maybe feeling that your partner is driving you nuts because you're, living in close quarters and really kind of on each other all the time. So we are able to provide services to a very broad spectrum of folks, and that on-demand care allows people to get care when they actually need it. Coaching is a really powerful modality, as I mentioned before. It's kind of an untapped labor pool. And so we have a lot of folks that are wanting to come on the Ginger system, coaches interested in working with us. And because we do so much training, over 200 hours a year for these coaches, they are highly trained in everything from using cognitive behavioral interventions to using motivational interviewing to help people get to the right levels of care. We also firmly believe in evidence-based care. We know that there is a lot of research out there that suggests what works best for certain individuals and groups of folks. So we're relying on that evidence to make sure that the care we deliver is high quality and that it's effective. We like to say that our clinicians are supercharged by technology. And so what this means is that we really believe that human-to-human interaction is very powerful. And there are a whole lot of data points on our system that we pull from. So things like measuring PHQ-9, so depression symptoms, GAD-7 for anxiety, looking at interaction patterns, seeing how often someone's using our system. All of this information can be surfaced very quickly to our team, and that helps them understand, oh, this person is not getting better, or I need to reach out and do a risk assessment on this person because they're indicating some thoughts of maybe wanting to harm themselves. So we use all of this technology to really buttress the care team, make sure they can make effective care decisions as they need to. And then one of the other things that's really important to us is doing a lot of work around diversity, equity, and inclusion. So we have done a lot of training with our care team on how to provide culturally responsive care, meaning that it's important that our care providers know that they have a worldview or a lens through which they view the world, and they're not imposing that on others. We're also teaching them about particular populations, interventions that might be helpful for particular groups, so that they're able to really provide care that is congruent with the member's needs. We also are investing heavily in matching, and we know that this is not sort of the end all be all. For some folks, having a provider who is a shared identity can be really important, but not for everyone. But we do have a very diverse care team. So I think over 40% of our coaches and clinicians at this point identify as one of the BPOC groups. So that's something that's very important to us too. We know that really drives engagement, helps members feel engaged in their care, adhere to treatment recommendations better, and stay on our system so that they get the care that they need. So if we can go on to the last slide. And I think really important for this audience is that we are very invested in metrics. So we're measuring a member's experience all along their care journey. So from the first time they come on our system, we're asking questions, we're deriving that data so we can understand if they're getting better or not. What we're looking at here are some of our results using the PHQ-9. So this is again a depression inventory. On our system, we are really seeing the additive value of coaching and clinical services. We have some data around this to really show that it is that collaborative model that really drives change. But across our system, when we look at depression symptoms, we're seeing that 70% of folks have a significant response in their symptoms. Now, this is compared to one of the seminal studies in the field, which is around 30% of folks have that same level of response. So it really speaks to the efficacy of care, the fact that it's done remotely through a cell phone. These things really increase access and decrease stigma. So it's really beneficial to members. They're making a lot of progress. They're really showing big gains from our system. We also look at member satisfaction. So we ask members to evaluate their coaches and their clinicians on a 5-star scale after every interaction. And that's to help us with QA, to make sure that members are satisfied so we can reach out if there's anything that's not gone well and fix it and do better. Typically, we have very high rates. So between 4.7 and 4.9 is how our coaches and clinicians are rated. So I think the kind of take-home message here is that mental health in our country, the system is really broken. We have seen this become more obvious during COVID. We know that there are marginalized groups who always have had difficulty accessing care. all of those things have become exaggerated over the last few months. So huge increase in utilization at coaching and clinical level. And part of the solution has to be using technology and flexible systems so that we can really provide care at scale and make sure that those who need it most are able to get their needs met.
Well, that's fantastic, Dana. Thank you so much. It's can't wait to talk about that in the Q&A, because I'm sure we'll have a lot of people who want to learn more about that. So I'd like to introduce Gina. Gina Trigani is the Director for Training and Capacity Building at Health Promotion Council. She contributes over 30 years of industry experience with an undergraduate degree in nutrition and dietetics from Drexel and graduate studies in public management and administration from Philadelphia College of Osteopathic Medicine. So for the sake of time, because we are running behind, I'm going to go ahead and hand it over to you, Gina, to take us through your innovative activity approach.
Thank you. Thank you so much, Scott. I first want to extend my gratitude to the National Alliance for having us on this esteemed panel today. I am absolutely honored to be here and to share our experience in utilizing Walk with Ease as an innovative approach for increasing physical activity in a multi-state workforce through partnership between the Health Promotion Council and the Greater Philadelphia Business Coalition on Health. Next slide, please. The work was funded by the National Association of Chronic Disease Directors through a cooperative agreement with the Centers for Disease Control and Prevention. Other key partners in this work include MedWorks, Resources for Human Development as our employer partner in this program, and Thomas Jefferson University, who partnered with the Greater Philadelphia Business Coalition on Health for program evaluation. Next slide, please. Walk with Ease was developed as a self-management program for musculoskeletal pain, which you can see here, reported in 2012 to be one of the top 3 most self-reported medical conditions in age groups 18 to 74, with a slight leveling off at the age group of 75 plus. We also see that history shows an increasing prevalence of and progressions to reach approximately 70 million in just 5 to 10 years. Next slide, please. The associated costs of arthritis is alarming with respect to medical and earnings loss. The key here is that physical activity is a low-cost intervention that can help control these costs. Next slide, please. The self-directed enhanced Walk with Ease arthritis intervention is evidence-based out of the Arthritis Foundation. It's a low-cost remote offering with online recruitment and registration. Participants work at their own pace through a 6-week guided curriculum. After receiving a Walk with Ease guidebook, they are encouraged to walk at their own pace, starting time with encouragement to increase their total time to walk 30 minutes, 3 days a week. The reading is supplemented by a Walk with Ease coach that works with them remotely with weekly motivational emails and phone consultation as needed. The program can supplement other well-being offerings, such as the National Diabetes Prevention Program, which requires 150 minutes of physical activity per week, and other disease management interventions. Next slide, please. Our employer case study offered this program to all 5,000 of its employees as a low-cost physical activity program, rather than targeting only those with arthritis. Completers were those who completed the baseline, midpoint, and final surveys after enrolling in the program. We had an excellent completion rates among the participating population. And the average, as you can see, the average age was 45, mostly female, and there were an array of comorbidities for which physical activity have been proven to have a positive impact. Next slide, please. The summary of our results, you can click through. We saw a doubling of participants walking 4 or more days a week, and a progressive increase in those walking 30 minutes, 3 or more days a week. And moreover, improvements in perceived health status, pain, fatigue, and confidence were actualized. Next slide, please. Likewise, we found improvement in overall productivity, noting that the last surveys that we collected were completed between March and May during this year of COVID-19 quarantine period. Next slide, please. Participants also felt positively about the program, finding it overall and helpful and extremely helpful, and noting improvements in both physical and mental health. Almost 60% reporting that it helped with weight loss and achieving those goals, and 95% indicating that they wanted to stick and intended to stick with the program. Next slide, please. Overall, we received positive feedback regarding the program, and that it was easy to follow. They liked that they were able to go at their own pace, all the while having appreciation for support, and then the ability to choose social interaction or to work on their own if they wished. And as you can see, there were several potential enhancements that could be addressed by including Walk with Ease as a part of an overall wellness program that offers activity tracking or social media engagement and other professional support, such as a registered dietitian, a health coach, or a personal trainer. Next slide, please. Physical activity, in summary, is low cost. So Walk with Ease provided the physical activity at a low cost model that's flexible and demonstrated high participant engagement, satisfaction, and positive outcomes. Next slide, please. So if you have any questions or would like to learn more about our approach to activities, please feel free to reach out to myself or my colleague, Neil Goldfarb at the Greater Philadelphia Business Coalition on Health. Thank you.
Thank you, Gina. That was wonderful. And again, I look forward to questions. You can either put them in the Q&A or you can put them in the chat. We'll pick them up. And Gina, I really appreciate your insight and look forward to hearing what the audience would like to hear more about. So if we could go to the next slide. Next up on our agenda is Sean Duffy from Omada, a company that most of us, I think, are very familiar with. He's the co-founder and CEO of Omada Health, a digital care company that works with health plans, employers, and health systems to address chronic conditions, including diabetes, hypertension, and musculoskeletal. The company also provides mental health support for those individuals dealing with anxiety and depression. So with that, I'd like to go ahead and turn it over to you, Sean, to tell us a little bit about your innovative, actually, I guess for Omada, I guess it's really innovative continued evolution of your platform as you've responded to more and more individuals over the last several years.
Yeah, absolutely. Well, thank you, Scott, and wonderful to be here. I think as you shared, Scott, a lot's changed at Omada over the past 8 years when I founded it, which was actually as a medical student. So hope here is to cover 4 primary things in 5 minutes. One is just a vision of what digital care can do for the world. Secondly, the set of capabilities that one needs to really optimize for outcomes and value. Third, condition areas that are just suitable for this approach. And fourth, how we ensure that the world trusts digital care. So with that, if you could take it to the next slide, we'll get started here. So if you were in the walls of Omada and, in COVID environment, in the walls of my home office here, you'd hear a mantra constantly discussed, which is in-person healthcare is option B. This was something that we've talked about many, many years before COVID hit. And it's on the belief system that in-person care is critically important. Yet, why would you not ask if you can deliver care services from afar without immediately jumping to, oh, well, that person should come into my office in my setting. So the mental model is, well, see if you can solve a care need from afar conveniently, effectively, and affordably. And if you do that and you have it as a cultural mandate across your organization, you can realize a transformation in care delivery. So that's what the path we've really been on from day one here. I will say what's happened during COVID is it's accelerated this transformation. I think we're all feeling that because fundamentally, over the course of March and April, hundreds of millions of Americans woke up and asked, can I get care from afar or do I need to go in? And that's pulled demand forward for new care experiences that I think is dramatically changing kind of the healthcare system. So if you could go to the next slide, I think it's always important to describe a vision for what digital care should and shouldn't be. Another mantra you'll constantly hear is digital care made human. So I think oftentimes when people hear the word digital, you can too often jump to the conclusion, well, okay, great, we're going to be talking with a bot here, and AI is replacing the doctor, similar to a lot of what the other panelists have shared here. I believe that's the wrong approach. I think that there's a reason that artificial empathy is not a buzzword, while artificial intelligence is. So humanness needs to come through a care experience. So at Omada, all of our participants are really given a dedicated proactive health coach that gets to know them and helps deploy our capabilities in context. The other thing that we tend to emphasize as we share our vision for digital care is that no one thing's going to cut it. There will never be the best connected device that delivers the outcome, the best community, the best content experience, just a coach, goal architecture, you name it. For the things that are suitable for digital first, you really have to have a full set of capabilities. And we often joke that we have 9 digital health companies as one, because you will find companies that specialize in each of these sub capabilities. And we think that you've got to really have a holistic, all hands on deck, drop in the paratroopers approach to deliver, promise and outcomes and value. So if you go to the next slide, these are the condition areas that we focus on in Omada. So really you can think of Omada as a digital center of excellence in each of these. The reasons that we felt that these were where Omada wanted to deploy, our vision is really the following. We share a belief that you need to think very, very critically on, is digital the right modality for care? So if you look at the metabolic spectrum, so pre-diabetes, type 2, and hypertension, and you sit for a minute in the homes of people with those conditions, you quickly realize that the capabilities of the in-person care system are not suitable to deploy the stitching between the visits and all the longitudinal contiguous support that patients need to deliver the right experience to improve outcomes. Same holds for behavioral and same holds for musculoskeletal. These are condition areas where you can accomplish so much from afar. And all of these also share the common characteristic of conditions that we hear about from our employers in our health plans that we work with. Where on our journey, we've often gotten asked at customer summits and either on the employer or the health plan side, well, has Omada ever considered this or that? Has Omada ever considered musculoskeletal? And so that led to this condition capability area, and that's where we focus. And the goal is to make sure that in each of these we're excellent. If you go to the next slide. But us saying it's not alone, alone is not enough here. Omada has been and will remain committed to evidence generation in real world outcomes here. I think it's timely because last week we just announced the results of a foundational landmark study in diabetes prevention, the largest ever randomized controlled trial ever done in the digital diabetes prevention space. That's level 1 evidence, and that's been many years in the making. And so that's something that we've cared about, a lot, because I've known, based on who my former classmates were at medical school, how critical that audience can be. And that, I think though it's changing, when we founded Omada, digital health was very much the underdog. And the only way to really gain support in the system is to lean into the generation of outcomes and really showing the merits of what you do. In the next slide. And I won't get into each of these, but in every single of our condition areas, we're extraordinarily proud of what we've been able to accomplish clinically. The approach for Omada is to baseline take stock of what has been shown to work in person. What are the foundations of science that we can build our programs upon? And then as we do it, make sure that we're showing outcomes, that the community that we support cares about, principally our employers and health plans, to really lift the power of digital care. So, that's all for me. And the only closing statement I make here is, I think we're at the very beginning of what digital care can do. I think in many circles, there's kind of an open debate and question on, well, how big will digital care get? What's going to happen here? And I think that if you look at the magnitude of the crises in just the disease areas that we support, our participants with at Omada, and you look at the penetration of companies like Omada, and others, we're just scratching the surface of what can and should be done. Is really a mandate to drive better outcomes and reduce costs across the system. So thanks for listening to our vision, and hope you get a sense for really the why behind Omada.
Very impressive, Sean. Thank you. If we can go to the next slide. We are now there. Nicole was going to be here today. I hope you can go to that. And unfortunately, she had a family issue come up, and she's not going to be able to join us. So I am now the surrogate corporate representative on the team. Go ahead into the list of everybody who, right there. So I'm going to start off and just ask Dana Udall the question that did come in for us. And we would love for more of you to send questions in now. But Dana, that is, when you define your mental health team or experts, what is the scope of their licenses or experience?
Absolutely. So we do have the 3 levels that I mentioned. We have coaching. Those are typically master's level providers. There is no licensure for coaching, but most of our folks have the national coach certification. And then we have licensed therapists. Those could be doctoral level or master's level, but licensed therapists and licensed psychiatrists. And so we have those in all 50 states, and they're able to work with the coaches to provide a coordinated care plan and really make sure that people both start at that coaching level, can step up to therapy and psychiatry, and then coaching provides that longitudinal support that allows people to step down and continue to have some level of care, given that in many systems you stop therapy or psych and then that's it, you've got nothing. So the coaches really provide that longitudinal support.
Thank you, Dana. So I'd like to reflect on the big picture. We have actually 17 minutes, and I want to get some dynamic repartee going back between those of us who are on the panel. And so to set that up, as a person who advises corporations, I'm constantly struck with the fact that there are all these gee whiz, wow, beautiful, really sharp, very expensive sales programs that are brought to corporations that are they drop out of the sky, and we're going to solve all your problems, and all you have to do is sign up with us and your healthcare costs can go down. And then you've got the guys like me and ladies like me that are family docs that are in the trenches trying to figure out how to help these folks day in and day out, and really not feeling supported by corporations. Our conversations with corporations tend to come from VUCA, who tell us what we can and can't do, and they put restrictions around us, and so it feels very, very constraining and a very antagonistic relationship. What do you see as the new normal, where we actually take amazing tools and solutions like you're bringing and bring that together with the primary care, and then together put that in place at corporations, or bring it to corporations so that there's a synergy, a 1 + 1 = 3, instead of a 1 + 1 = 1.5, and the corporation's left writing a bunch of very big checks. So what's the relationship between your product, primary care, and how does that come together to serve the corporation? And I won't call on anybody. I'll let you guys jump in. That's a tough question, I know.
I'll bite.
I'll go for it. Yeah.
This is Bert. As you were talking, Scott, I was thinking about a Kaiser study that was done in the summer of 2019. I think the title was Americans want their doctor to be asking more about what's going on in their lives, and doctors just don't have the time. And so, as I think about and reflect on the question, if there are programs in the workplace that are intended to kind of cut across what is currently a point solution system of employee benefits, there might be more of an acknowledgement of what's going on in that person's world, so that attention could be paid to it, and social work resources could be brought to bear, perhaps through the workforce. And then, as I think about it, referrals from primary care into the programs themselves would really go a long way. And I know there are certain billing codes now for certain services, but if you can find a way to and this is not at the primary care level, but maybe at the CMS level, to reimburse and make it worth that primary care doc's time to be able to devote to some of these things. So, unfortunately, it is a billing and time and bandwidth situation with the primary care doc, but if there could be more of a programming connection, so that the docs know that the employers have programs in place that people actually use and are connected to helping them and solve for what's in their world.
Well, Bert, I would tell you, I would kill to have the ability to send my patients into your program. It would completely transform what I'm able to do for the patients. And, with the on-site, near-site clinic movement in the United States, and given the fact that we're talking population health today, that means data. I wonder if we couldn't come together and have a set of algorithms that the data would actually inform which employee belongs in your program and wouldn't link them, and then you would be given the primary care information and you'd be able to share it with them. So maybe we just need to reverse engineer that. Sean, what do you think?
Yes, I think it's an awesome question. I mean, I literally, I'm having this conversation on almost a daily basis with my former classmates from medical school, many of which are practicing primary care docs right now. And I think what you've highlighted is something really important, where the innovation that's happening on the employer and the plan side doesn't always land in a way that it amplifies the everyday life of a primary care doc. I do think that there is a different world. I do think it's coming. I do think it'll take time. I'll use our prediabetes intervention and diabetes prevention program as an example. You look at every single practice guideline that's relevant in the space. You look at what USPSTF says for someone who walks into a primary care doc's office and shows up with an elevated glucose profile and has prediabetes. It all says refer to an intensive lifestyle intervention modeled off foundational literature. There's zero dissonance that that's the case. The challenge is, how do you actually get that into practice, and how do you educate primary care docs that that's feasible and possible? How do you earn their trust, and how do you operationalize it? So fundamentally, we felt that unless you have research that shows that your program works, you're not going to be able to cross the barrier of getting support from clinicians. It's a skeptical audience. You want to know that if you're referring your patient somewhere, that it's actually going to work, and you want to see demonstrated, ideally randomized evidence that that's the case. And secondly, you need sufficient coverage, and the reimbursement model has to hang together, because if only 5% of your patients are actually going to be covered for the solution, there's no way you're changing your practice. Yes, maybe there's a future vision where, an EMR can identify which employers have coverage, but it's almost too much to remember if you have, this huge palette of interventions and every patient has different coverage thresholds. So there are certain pockets where, because of this virtual employer and plan cycle of adaptation of Omada's offerings, we actually have sufficient coverage where the majority of patients that walk into a primary care doc's office actually have Omada as a benefit. So I'll use North Dakota as an example. Thanks to some new plan relationships there, there's probably a 60-70% chance that any primary care doc in North Dakota that's practicing can have a patient that walks in with prediabetes and can effectively refer into Omada. So it's a real endeavor to enable the cycle. I think it's going to come. I see the flywheel starting to materialize in a way that will result in the feasibility here. But it's one that I think collectively as a system, we've all had to be patient for, but feel more optimistic that we're on the cusp of seeing this in practice than ever before.
It's fantastic to hear. You went all the way to the private doctors in practice, which I think is amazing that you're even thinking at that level, and I respect that so much. I was, again, back at the on-site near-site clinic where 100% of people in a corporation is covered, and how even at that level, how often there's the right and left hand don't communicate. So that's fantastic, Sean. Thank you for sharing that. And congratulations on your success in North Dakota. And Dana, you talked about evidence-based medicine as you were going through. I think the biggest missing as a primary care doctor is mental health. I literally am not trained in it to handle anybody other than just, adjustment reaction with mixed features. And yet there are no resources in the community. So I believe that what you've created, what Ginger is an example of the future of mental health in America. How would you see that bridge between primary care and mental health with vehicles like yours coming together?
Yeah, I think you just hit the nail on the head. It is that behavioral health and primary care are delivered in silos with very little communication, very little oversight, which is a huge mistake because we know that there is such a high correlation between medical issues, something like hypertension or diabetes, and mental health issues such as depression. So if we're treating these two things in isolation and there's not good collaboration, then people don't make progress, and you could potentially have a worsening of both conditions as a result. So one of the things that we have recently done is launched a partnership with Accolade, and it is really to integrate at these two levels. So integrating with their primary care providers, having conjoint rounds meetings so that we're really ensuring that we have this system. We also do work with healthcare systems in which they can prescribe, not really prescribe, but in which they're recommending. These are clinicians, primary care docs who are saying, here, Ginger would be a great solution for you. Let me help you get set up with that. So the bridges are being built. We need to create the infrastructure, so the pipes to allow us to seamlessly exchange information. That's always been a huge headache, is that, EHRs that are separate and don't talk to each other well, and the old sort of doc-to-doc conversation after signing a written release of information is not scalable. So there are a lot of things that we're doing to create more seamless exchange of information that is really patient-centered. And I think there's still a lot of room to go. So lots of progress that we've already seen and that we are trying to push forward, and still lots of innovation that needs to take place before we really get to the ideal state.
Got it. So Gina, do you have any thoughts on this that you'd like to share with us? I know that your program is not quite focused on this, but I'd love to hear your thoughts.
Sure, thank you, Scott. Yeah, what comes to mind is Resources for Human Development, our partner. It's interesting that you're talking about the primary care setting. So HPC is positioned in a place in that community clinical space. So we work with both community-based providers, not only us providing direct services, but with many other organizations locally and statewide that offer programming. So what we do is really try to work on engaging primary care providers, engaging health systems, engaging the community providers, so that we can make these programs more accessible to primary care. And most importantly, getting the information back to the primary care providers, especially from the community-based organizations. And the point that I was going to say about Resources for Human Development, while it was an employee-focused program, a lot of their services are patient and client focused, whether it's mental health provision, federally qualified health centers. So they really are a well-rounded organization. So impacting employee health eventually will have that trickle down into the primary care setting and the mental health setting and the behavioral health setting as well.
Clear. Well, thank you for those thoughts. So we've got several more minutes, and really for the I'd really love to have you all talk about in terms of what you see the new normal being in America today. You know, as you know, Pfizer came out and the immunization far exceeded expectations. 90% they're saying effective. 40% was what we'd hoped for, and 90% is life changing. And the market responded. Everything's changed, and many people are saying that, as an example, with the vaccine, the digital health, the telemedicine, we're in a new place today, and we're never going back. And so I'd like to turn it over to each of you to take a minute and a half to say what I see that's changed in medicine today is this. As if I were a corporation, I would be leaning into this. So just leave your lead behind for corporations as they think about the next 12 months of how things have changed and what's possible for them today that wasn't possible a year ago. Sean, let's let you go first. What do you say?
Well, I think what won't change is a continued ask from the workforce to have incredible digital care and digital solutions. That's not going away. It's going to become a talent expectation. You know, I think because of COVID, because innovative employers have tried new things to bring care into the homes and the pockets of their employees in response to COVID. And many instances, you know, folks have found that they liked, you know, what they see. I think that, you know, a little bit of ebbs and flows, like not all of the utilization that you see digitally will remain that you see in COVID, because there are just practical realities of what you need to do to support someone in person, as shared at the top. But I think for the digital care areas where you can deliver the vast majority of care from afar, that's going to become the base case standard. And it's going to become a talent expectation and a competitive expectation for employers to have offerings.
Great. Okay, how about Bert?
Yeah, in answer to your question, I would say if you're an employer today coming out of COVID, you should be looking at your employee benefits suite and say, how did that work for you in supporting your workforce through all the stress and anxiety of COVID? And you know, this paints a picture. Everybody's different, but you have extended families that moved in together. And all the stress and anxiety that goes with multi-generational families and all under the same roof. And the benefits that exist in an employee benefits suite are to help with this are things like an EAP program. And, you know, a couple of our customers come to mind where during the March and April lockdown, you knew that everybody was adjusting, but the data would suggest that nobody was calling these support services. So so there's, yes, the need for digital, as we're all talking, and being able to access care remotely, and having access to a breadth of resources. But I look at, if you're an employer, you have to say it's time for a new model. And these out-of-the-box programs that have been there to support my employees, nobody's using them, they don't work. I would argue there's even a cooling off period if somebody raises their hand and said, I need help. The best an employer has right now is to say, here's a pamphlet, call this number. And these kinds of benefits just don't work. And I think COVID has exposed that. And it's going to expose a lot more mental health issues and loneliness and that sort of thing.
Very good. Thank you so much for those thoughts. Gina, would you like to go next?
Sure. Thank you, Scott. For me, I'm thinking about just, what are the social determinants of health, and just what do people need to stay connected and to make behavior changes that are needed for their all around health. And, what can employees do to really look at the human side of delivering programs and making resources available. That's really what I would have to say.
Thank you. And Dana?
For me, the kind of take home really is the idea that I think mental health is moving from margin to center. So I think it is just so crucial when we're talking about mental health, benefits packages at large, that mental health has to be a key piece of that. I think for an employer thinking about creating a solution or identifying a solution that is both flexible enough that your employees will really use it and flexible enough that it might exist in concert with your existing structure. So if you have an EAP, if you have something that is already working for your population, how can a new vendor come in and really integrate with that so that it solves your issues as well? So it's not just about your employees, but it's also about the employer. Really creating that level of integration and partnership across your system of benefits is key.
Got it. I will close this out today by saying what you've heard today from these innovators is several key themes. Number one, generic out-of-the-box programs don't work. Bert hit the nail on the head, and disease programs don't work. People aren't diseases. I can't tell you the number of times it's been offensive to have somebody with stage 4 cancer get a call from a diabetes nurse on their new diabetes program from their corporate sponsor. It's just not okay. People are human beings. And what you see with the evolution of Bert's program, where you're looking at whole people, with Omada, when they're looking at a more comprehensive suite of services, starting with prevention and ending up at musculoskeletal, with Dana's integrated platform of mental health, where it's not enough to just do stress coaching, which is another thing I see all the time. They'll get a call from work. Hi, I'm your coach. I'm going to help you with a better lifestyle. And they're like, well, what are you going to do about the fact I can't afford my medications? I've got diabetes that I can't control now, and I can't get my kids to work every day. Oh, don't worry. We're going to talk to you about your diet and exercise. Those programs have failed. They're gone. They're history. Quit spending money on them. And particularly these big, health plan programs where all you have to do is add $2 a month and it's all going to be okay. I think that we've learned that's not going to work. So number one, out of the box doesn't work. It's got to be personalized and individualized. It's got to be based on data where it literally resonates with that individual and they feel compelled at a heart level, not at a mind level, to interact. And to do that, it's going to be an integration of digital, which again, when you think data, digital, and the ability to seamlessly bring things to people easily, and human. Because the digital, as Sean said very well, has the AI, but it doesn't have the human empathy. And without human empathy, it's just another waste of your money. So 2020 has become the year of innovation adoption by necessity. Companies can't go back. They must lean into a new normal, incorporating population strategies with the integration of digital and human interaction and care. Generic programs are no longer enough. Personalized and individualized solutions are necessary. And what a brilliant group that the National Alliance today has had the honor of bringing to you all to share what's going on today and what's coming tomorrow. So with that, I'd like to thank everybody, wish you the best, stay safe, and we'll look forward to interacting with you online. God bless.
Thanks all.
Thank you.
Thank you.
Take care.